Welcome to the presentation titled, Why Should You Focus on Improving Antibiotic Use? And my name is Pranita Tema. I'm an Associate Professor of Pediatrics in the Division of Infectious Diseases at Johns Hopkins Medicine. I also serve as the Director of the Pediatric Antimicrobial Stewardship Program at the Johns Hopkins University School of Medicine. And I see patients in the hospital, in the clinic, and over telemedicine. And I'm one of the leaders of this antibiotic stewardship project, along with my colleagues at NORC at the University of Chicago and Johns Hopkins University. So should you have additional questions after this webinar, please note the safety program's email address on the slide. We wanted to welcome all of you to this webinar. Some of you might be coming from practices where you see some patients in person and others virtually, and some of you might be coming from practices where you see all patients virtually. And none of the presenters have any conflicts of interest relevant to this program. And the faculty and the planners are managers for the Postgraduate Institute for Medicine, Johns Hopkins University. AHRQ and NORC also have nothing to disclose. And just a few more logistic information. In support of improving patient care, this activity has been planned and implemented by the Postgraduate Institute for Medicine and National Opinion Research Center. Postgraduate Institution for Medicine is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. And for physicians, CME, this live activity is designated for 1 AMA PRA Category 1 credit. This activity is designed for 1 AAPA Category 1 CME credit. For continuing nursing education, the maximum number of hours awarded is 1 contact hour, and this activity is designed for 1 IPCE credit. And successful completion of the CME activity, which includes participation in the evaluation component, enables the participant to earn up to 1 medical knowledge MOC points, up to 1 practice assessment MOC points in the American Board of Internal Medicine's Maintenance of Certification Program, and up to 1 MOC point in the American Board of Pediatrics Maintenance of Certification Program. Okay, so now to the actual presentation. We'll be using a clinical case-based format to discuss why focusing on improving antibiotic prescribing is a patient safety issue. By the end of this presentation, participants will be able to explain why optimizing antibiotic prescribing is necessary for patient safety, understand how antibiotic stewardship can improve antibiotic prescribing practices through telemedicine, and describe the 4 moments of antibiotic decision-making in Telemedicine Framework. So the discovery of antibiotics has saved countless lives. For patients with bacterial infections, prompt administration of the right antibiotic at the right dose can be critical to improve outcomes. However, all antibiotics, whether necessary or not, are associated with potential risks, and ensuring the potential benefits of antibiotics outweigh the potential risks is critical every time an antibiotic is being considered. When an antibiotic is being considered, it's important to consider potential side effects. Examples of adverse events include allergic reactions, rashes, acute kidney injury, hepatotoxicity, seizures, gastrointestinal issues such as diarrhea, nausea, vomiting. For certain antibiotics, there can also be more specific and sometimes severe reactions like Stevens-Johnson syndrome, as will be discussed in future presentations. Additionally, antibiotic use is the primary driver of antibiotic resistance, which makes future infections in that same patient increasingly challenging to treat. At least 30% of all antibiotics prescribed in the outpatient setting are not needed and may lead to avoidable harm. A successful approach to work toward the common goal of safe and effective antibiotic prescribing is to incorporate antibiotic stewardship into your daily practice. Antibiotic stewardship means all patients who need an antibiotic receive the safest and most effective options, and patients who do not need antibiotics do not receive them. Practicing good stewardship will improve patient satisfaction, as it will help patients understand why a decision is being made to prescribe are not to prescribe antibiotics. So consider the following case to underscore why optimizing antibiotic prescribing is necessary for patient safety. A 62-year-old man with no past medical history presents via telemedicine with 1 week of an increased non-productive cough after a visit with his grandson. The cough is disrupting his daily activities and his sleep. He reports no fevers. When he is examined via telemedicine, his provider requests he removes his shirt and documents that he appears to be breathing comfortably, is speaking in full sentences without shortness of breath, and has a normal respiratory rate. The patient denies any chest pain. He is prescribed 7 days of levofloxacin just in case he has bacterial pneumonia. The patient contacts the provider through a secure portal message on day 6, noting although he remains afebrile and otherwise unchanged, his cough has not improved. The provider who receives the message extends the levofloxacin prescription to complete a total of 10 days of antibiotic therapy. 1 week later, the patient presents to the hospital with severe Clostridioides difficile infection. He requires admission to the intensive care unit and spends 10 days in the hospital. The patient was most likely misdiagnosed with having community-acquired pneumonia and given an unnecessary antibiotic. And this was at least in part likely because the provider thought the patient wanted an antibiotic, even if the provider might have otherwise thought the patient did not need the antibiotic. A number of factors led to this patient having a poor outcome. First, his history and physical exam are most suggestive of acute bronchitis. He has not had fevers, increased work of breathing, shortness of breath, or chest pain. Acute bronchitis is generally caused by a virus, and therefore antibiotics are not necessary. Bacteria are uncommon causes of acute bronchitis. In a study of 780 adults with acute respiratory illnesses, bacteria accounted for only 6% of cases of acute bronchitis. Second, even if there was concern for community-acquired pneumonia, levofloxacin is not first-line therapy, as we'll discuss in future presentations, and rather should generally only be considered in cases of severe penicillin allergy. Further, the duration of therapy for community-acquired pneumonia is generally 5 days, not 10 days. Levofloxacin is a very broad-spectrum antibiotic that increases the risk of C. difficile infections, and this risk increases with each additional day of antibiotics. Again, in future presentations, we'll discuss the diagnosis and appropriate antibiotic treatment for community-acquired pneumonia, as well as other potential adverse events associated with fluoroquinolone use. After several days of antibiotics, the patient's symptoms remain changed, suggesting that a viral process was likely. The decision to reconsider the need for antibiotics did not occur. It was appropriate to reevaluate the patient via telemedicine on day 6 when he was concerned about his lingering cough. A repeat evaluation is necessary to ensure that he does not have concerning signs or symptoms that are now suggestive of a bacterial infection that would require an in-person visit. However, on day 6, the patient reports symptoms being unchanged, including no fevers. The patient's symptoms remain most suggestive of a viral process. Rather, a decision was made to extend the treatment course by an additional 3 days, despite no evidence of a bacterial infection or demonstration of a response to therapy. These extra days of exposure to a broad-spectrum antibiotic may have further increased his risk of C. difficile infection. In the case presented, the patient developed a severe C. difficile infection. Virtually all antibiotics can increase the risk of C. difficile infections. However, the greatest risk occurs with clindamycin, third-generation cephalosporins, and fluoroquinolones. In fact, fluoroquinolones appear to be the antibiotics with the strongest association with a future C. difficile infection. Patients who receive fluoroquinolones have almost 13 times the odds of developing C. difficile infections compared to patients who do not receive these agents. The risk of C. difficile infection is highest when patients are actively receiving antibiotics, but this risk remains elevated even for several months after antibiotics are discontinued. A number of factors influence antibiotic prescribing decisions beyond clinicians' knowledge of infections and antibiotics. Clinicians may be concerned that they'll be viewed as dismissive or disrespectful if they stop or change antibiotics started by another clinician. Clinicians may also worry about reactions from patients or family members if antibiotics are not prescribed. However, inappropriate antibiotic prescribing is a safety problem as it exposes patients to unnecessary risks. Implementation of antibiotic stewardship practices and daily decision-making ensure that patients receive antibiotics only when needed to minimize harm and maximize the chance of a good outcome. And in future presentations, we will be discussing communication strategies to handle some of these scenarios. Throughout the HRQ safety program, we will be discussing best practices in the diagnosis and treatment of common outpatient infectious concerns over telemedicine using a clinical-based, case-based approach. We will use a framework called the 4 moments of antibiotic decision-making to ensure that critical questions are being considered when we decide whether or not to prescribe an antibiotic. This framework will help ensure that patients who need antibiotics are receiving the safest and most effective agent, that antibiotics will be avoided in patients that are unlikely to benefit from them, and that care will be escalated to in-person visits for circumstances where virtual visits may not be appropriate. Moment 1 is my patient an appropriate candidate for a telemedicine visit? This moment identifies patients who likely should be referred for an in-person visit, in-person evaluation based on the clinical presentation. Moment 2 is, does my patient have signs and symptoms indicating an infection that require antibiotics? Is a diagnostic test indicated? Moment 3 is, if antibiotics are indicated, what is the narrowest, safest, and shortest regimen I can prescribe? And finally, moment 4 is, what symptoms should I offer or prescribe to my patient? What should I tell my patient about the expected course and the follow-up plan? So in summary, although antibiotics are necessary for many bacterial infections, as we'll discuss throughout this series, all antibiotics also have the potential for associated harm. Incorporating antibiotic stewardship principles into your antibiotic decision-making will assist you with remaining up to date on best practices in the diagnosis and treatment of infections, improve communication with your patients and colleagues around antibiotic prescribing, and improve patient satisfaction. A structured approach like the 4 moments of antibiotic decision-making will help facilitate the effective use of antibiotic stewardship into your medical decision-making. And in future webinars, we'll actually discuss individual antibiotics and specific adverse events to notify your patients about when you prescribe antibiotics. So after this program ends, your next steps are to go to the website, safety program for telemedicine.org. The main contacts at each practice should have received login credentials for the safety program website via email. And there you can review the webinar schedule for the upcoming webinar and office hours and watch recordings of past webinars. And as mentioned, this webinar will be available as a recording as well as a PowerPoint slide set with a script that you can download within 5 days following the second presentation of the same topic. And this month, the commitment poster for antibiotic stewardship and telemedicine is posted on the website. The commitment poster can be signed by clinicians and staff or include pictures of clinicians and staff to let your patients and providers know that you and your practice are committed to improving antibiotic use. Consider displaying this poster as a screensaver on clinic computers where healthcare workers can see it, on a virtual visit welcome page or login page where patients and families can see it, or as a virtual waiting room background where patients and families or healthcare workers can see it. You can also print the poster and hang it in a location in the room where the telemedicine visits take place. Posters are available as portrait and landscape format in 2 sizes, as well as a screensaver. And if you've not already a reminder to complete the welcome call with your implementation. If you've not already received it, a reminder to complete the welcome call with your implementation advisor will be sent to you. These are your main points of contact, your implementation advisor, and we'll work with you closely to answer any questions about the program, including help with website access, assistance with data submission or data quality issues. And if there's clinical questions, the implementation advisor will elevate those questions to myself or Sarah Keller. And you'll have monthly check-ins with your implementation advisors. If you have any issues logging into the website or other questions, please contact your implementation advisor or the safety program email address. So thank you for joining us for our presentation today. We invite you to now ask questions.